This is a recorded lecture for Chapter 21, the respiratory system, which is part of the Anatomy and Physiology 230 class. That will be the second semester of Anatomy and Physiology. Respiration, if you will, involves both the respiratory and the circulatory system, and it really feeds back to understanding the heart functionally as well as anatomically. The heart being actually two pumps. The pump on the left, which is a systemic pump, and the pump on the right, which is really the pulmonary side of the house, the pulmonary pump. And so when you talk about the respiration being involved in the respiratory and circulatory systems, you start to pick up on where that's at. There are four processes that supply the body with oxygen and help to remove carbon dioxide, oxygen being an important element as far as our respiration is concerned, our cell life, and CO2, carbon dioxide, being the leftover of that metabolism. We talk about the respiratory system, we're really talking about pulmonary ventilation, breathing, where we have movement of air into and out of the lungs. And then we have what's called external respiration, which is where O2 and CO2 are exchanged between the lungs and the blood. So from the outside world to the blood in the lungs, that's external respiration. As opposed to internal respiration, which is the exchange of oxygen and CO2 within all the tissues of the body. So so let's take a step back. The oxygen comes in from the environment, from the universe. We inhale it into our lungs. It is exchanged with the hemoglobin within the red blood cells in our blood in the lungs. And then it's taken back to the heart, where then it's transported throughout the systemic circulation, where it's fed to each and every cell of the body, all the cells of the body, and where O2 is given off and CO2 is taken on. So that's the process of respiration. So understanding external and internal respiration is going to be really important. Understanding what happens in external respiration and internal respiration is going to be really important. We talk about the respiratory system, and you'll hear respiratory system also. The major organs include the nose, the nasal cavity, the perinasal sinuses, the pharynx, the larynx, the trachea, the bronchi and their branches in the lungs, and the alveoli, which is really where external respiration takes place, is at the alveolar level. This is a really nice graphic which lets you feed into that and look at the anatomy as we talked about before. You can see the nasal pharynx here, the nostrils that opens the nasal pharynx. You see the oral pharynx, the common pharynx as you will, the larynx. We start to see the trachea as it breaks down the right and main stem bronchi, and then to the left and right lung. And then you see the diaphragm, which is located at the bottom of the thoracic cavity, which is where each of the lungs rests against, and helps us with air movement in and out of the thoracic cavity. The respiratory zone is really the site of gas exchange, and the microscopic structures include the respiratory bronchioles, the small bronchioles, and the alveolar ducts and the alveoli themselves. The conducting zones are really the conduits to gas exchange. So anything that brings air down to the respiratory level is really a conducting zone. And that includes all the other respiratory structures. So the only part of the respiratory zone is really the respiratory bronchioles, the alveolar ducts, and the alveoli. The rest are conducting zone. The respiratory muscles include the diaphragm and the other muscles that help to promote ventilation. But never forget, the diaphragm is the main muscle of respiration as far as external respiration is concerned. It's the main muscle. It's the muscle that promotes gas exchange from our internal thoracic cavity to the outside world. The first anatomical structure we'll talk about is the nose, and it functions to provide an airway for respiration. It helps to moisten and warm the air as it enters the nasal pharynx. It also filters and cleans inspired air through hairs within our nose, as well as the mucus that catches those other little small particles. It serves as a resonating chamber for speech, giving us some of the resonance of our sound. And it also houses the olfactory receptors, as you remember from the nervous system. They're located in the superior aspect, the roof, if you will, of the nasal pharynx. There are two regions of the nose, the external nose and the nasal cavity. The external nose is made up of the root, the bridge, the dorsum nasi, and the apex. The philtrum, which is a shallow vertical groove, which is inferior to the apex, is also part of the external nose. And the nostrils, which are really openings into the nose proper and are bounded laterally by the alae, and I'll show you those in just a minute. So there's the epicranius, the frontal belly, the epicranius muscle. There's the root and the bridge of the nose right there between the eyes, as it were. We have the dorsum nasi, which is really the bridge of the nose proper. We have the ala of the nose, the alae, if you want to talk about both of them, which are really that little, is really the edge, the flared edge on each side of the nose. We have the apex of the nose, which is kind of the point of the nose. The nares being the opening, one on each side. Also, there's the septum located in the middle, and then the little indentation just before the nose, which is called the philtrum. We're looking at the bones in there. Bones of the nose, you're really seeing the frontal bone here located, which makes up the superior orbital ridges and the initial part of that bone. We have the nasal bone proper, which makes up the most superior aspect. We have septal cartilage, which you'll see as it moves down. We have the maxillary bone, and the maxillary bone is really that bone that makes up the inferior orbital ridge, as well as the lateral aspects of the nose proper. We have the lateral process of the septal cartilage, which makes up that minor alar cartilage. We'll hear that. We have the dense fibrous connective tissue, which makes up the ala proper. And then we have the major alar cartridges located right here, so you get kind of a feel for what we're talking about. The nasal cavity in the posterior is in the posterior, the external nose. It's divided by that nasal septum I showed you before. And there's posterior nasal apertures, which open in the nasal pharynx, called choanae. The roof of the nasal cavity is made up of the ethmoid and sphenoid bones, and the floor is really made up of the hard and soft palates. The vestibule is a nasal cavity superior to the nostrils, and the vibrissae filter coarse particles from the inspired air. The olfactory mucosa lines the superior nasal cavity, and it contains those smell receptors we talked about before. The respiratory mucosa is pseudostratified ciliated columnar epithelium. That makes sense when you think that it produces mucus. Mucus and serous secretions contains lysozymes and defensins, which help protect us from invading bacteria, microorganisms. And the cilia move contaminated mucus posteriorly to the throat. And it's interesting, from the nose backwards, the cilia move the mucus towards the throat so we can swallow it or spit it out. From the bronchioles up, the cilia move from the bronchioles, deep in the bronchioles, up to the throats from that other opposite direction to do exactly the same thing. Inspired air is warmed by plexuses of the capillaries and the veins located in the nasal cavity. And the sensory nerve is trigger the sneezing from that location if something occurs. And you can get a really nice feel for this. What's been said, it'll cut, if you will, looking at the nasal pharynx proper. You see the nasal cavity, you see the nasal meatuses here, and you get a good feel for the nasal conchae, the superior, middle, and inferior nasal conchae. As we look at that, you see how air enters that. You see lots of surface area thanks to those nasal conchae that increase the surface area. And then you see as it becomes the nasal pharynx, and then it hooks up with the oral pharynx, becoming the laryngeal pharynx. So nasal pharynx, oral pharynx, and laryngeal pharynx, as you get a feel for what we're talking about. The nasal cavity has a superior, middle, and inferior nasal conchae I just showed you, and they're the things that protrude from each of the lateral walls of each nasal cavity. And they increase the mucosal area. They enhance air turbulence, so the air is mixed, if you will, and the particles that are located in are picked up. The function of the nasal mucosa and the conchae is that during inhalation, the conchae and nasal mucosa filter heat and moisten the air. During exhalation, these structures reclaim some of that heat and moisture. So they work both on exhalation and inhalation. The perinasal sinuses include the frontal, sphenoid, ethmoid, and maxillary sinuses, and they're located in those respective bones. They lighten the skull, they help to warm and moisten the air, and they also give some resonance to our voice. The pharynx is a muscular tube that connects to the nasal cavity and the mouth superiorly, or the nasal pharynx and the oral pharynx, the larynx and the esophagus inferiorly, and from the base of the skull to the level of the 6 cervical vertebrae. The pharynx, if you will, is really the nasal pharynx and the oral pharynx coming together in the laryngeal pharynx. So it's really 3 parts. There's the nasal pharynx, there's the oropharynx, and finally there's the laryngopharynx at the very bottom. Nasopharynx provides an air passage posteriorly to the nasal cavity. It's lined with pseudostratified columnar epithelium. That's a big surprise because it produces mucosa. Its soft palate and uvula close the nasal pharynx during swallowing, and the pharyngeal tonsils, the adenoids, are located in the posterior wall, and the pharyngeal tympanic auditory tubes really open into the lateral walls of the nasal pharynx, the eustachian tubes, as it were. We have the oropharynx next, which is just inferior to the nasal pharynx, and it's obviously the passageway for food as well as air from the level of the soft palate to the epiglottis. It's also lined with stratified squamous epithelium. We're so surprised, which produces mucus. The isthmus of the fauces, which opens the oral cavity. The palatine tonsils in the lateral walls of the fauces help to collect invading microorganisms and set up a place for the body to start to develop that primary response to those invading antigens. And the lingual tonsils are located in the posterior surface of the tongue. The laryngeal pharynx is the passageway for food and air. It's posterior to the upright epiglottis and extends to the larynx, where this also continues with the esophagus. So you get a nice feel for that. So we look at the nasal pharynx, you see that there. You see the oral pharynx, you see the laryngeal pharynx, and finally we come to larynx. And the larynx will be the next thing we talk about, where you see the epiglottis here locally. It's at the larynx, at the bottom of the oral pharynx, where the respiratory system and digestive system split. Because as far as the oral pharynx is concerned, it's both a organ of the respiratory system as well as the digestive system. But at the larynx, that commonality changes, and there's a split. Posteriorly, the tube, the esophagus, becomes digestive, and anteriorly, the larynx proper becomes respiratory. The larynx attaches to the hyoid bone, that's that free-floating bone in the anterior aspect of the neck, and opens to the laryngeal pharynx. It's continuous with the trachea, and it functions by providing a patent airway. It routes food and air to the proper channels. It's a place where they go in different directions. And it's also where the vocal cords are located, and so vocal production occurs or is created here. The larynx is made up of cartilages. One is the hyaline cartilage, all the cartilages are hyaline cartilage except for the epiglottis. The thyroid cartilage, it shows kind of a laryngeal prominence. There's the Adam's apple, it's located with that. And the ring-shaped cricocartilages, which give the larynx its shape so it's not easily collapsed. There are pararytenoid, cuneiform, and corniculate cartilages, and we'll show you those. And finally, the epiglottis, which is an elastic cartilage, which covers the laryngeal inlet during swallowing of food or fluid, so as not to block the airway. We're looking at the anterior aspect of the larynx. You can see the body of the hyoid bone. There's the epiglottis. It sticks up almost like a bird's beak. There's the thyrohyoid membrane. You can see that right there. And there's the thyroid cartilage, which is a very hard cartilage, which gives us our Adam's apple more prominent in men than women. There's also the cricoid cartilage located just before that, and right in the middle is a little set of ligaments called the cricothyroid ligaments, and that's really when you're going to do a cricothyroidotomy to create an airway. That's where you put the hole, as it were. And then we have the tracheal cartilages, and these are C cartilages, and you can't see it right here, but they're really open in the back. So they're closed in the front and the sides, but they're actually open in the back, and you'll be able to see those in just a minute. This is a side view. You can see the epiglottis right here as it closes over like a toilet seat lid, literally over the larynx. You get a nice feel for the body of the hyoid bone and located anteriorly. There's the thyroid membrane that we talked about, that fatty pad. We're seeing the thyroid cartilage right here. You see the cricothyroid ligament located right here. And then posteriorly, there's the thyroid membrane. There's the cuneiform cartilage we see here, the corniculate cartilage here, and the arytenoid cartilages right there. The cricoid cartilage you see there posteriorly, and finally the tracheal cartilage is again located in the lateral view, if you will. And then we'll see what you don't see on the posterior view is those thyroid cartilages. Excuse me, those tracheal cartilages are really open. They're really not. It's really not a closed circle. It's open in the back. Within the larynx are the vocal ligaments, the vocal cords, and they attach the arytenoid cartilages and to the thyroid cartilage. They contain very elastic fibers, and they form the core of the vocal cords, the true vocal cords. There's an opening between them, it's called the glottis, and the folds vibrate and produce sound as air rushes up from the lungs. So really, it's exhalation across the vocal cords that help us talk. There are vestibular folds, which are false vocal cords that are located just superior to the true vocal cords. They have no part in sound production, and they help to close the glottis during swallowing. So their function is really help close the glottis during swallowing. You see here, we see the base of the tongue right here. You can see this is the closed position, the open position for the both vocal folds. You can see the epiglottis located right here and right here. You see the vestibular folds located on the outside right here. You get a feel for the glottis, which is located right in the center here, and you can see this right here. And then you can get a feel for the cuneiform cartilages and the corniculate cartilages. So you get a nice feel for what we're talking about. We're talking about the vocal cords. Voice production is really speech, which is an intermittent release of expired air, while opening and closing the glottis to create different pitches. Pitches determined by the length and tension of the vocal cords, which allow us to singing and changing the tenor of a voice. The loudness of the voice production is really dependent on the air that's being forced out. The more air that's being forced out, the louder the potential sound. The chambers of the pharynx, oral, and nasal, and sinus cavities, which sort of amplify and enhance that sound quality. And so sound is shaped into language by the muscles of the pharynx, the tongue, the soft palate, and the lips. The vocal cords may act as a sphincter also to prevent air passage, and there's an example of that as Valsalva maneuver, where the glottis closes to prevent exhalation. The abdominal and muscles contract, the intra-abdominal pressure rises and helps to empty the rectum and stabilizes the trunk during heavy lifting. So there's a process that goes on called that Valsalva maneuver. The next part of the next structure we have in the airway as we're going from the outside in is the trachea. It's also called the windpipe, and it sits between the larynx superiorly and runs through the mediastinum. Its wall is composed of 3 layers. It has a ciliated pseudostratified epithelium in the mucosa. The submucosa is connective tissue with the seromucous glands. And finally, on the outside is adventitial, which is the outermost layer made of connective tissue, which encases those C-shaped rings of hyaline cartilage I talked about before. The trachealis muscle connects the posterior parts of the cartilage rings and contracts during coughing, and it helps expel mucus. The carina is the last cartilage ring, or last tracheal ring, last tracheal cartilage, and it's the point where the trachea branches into the 2 main stem bronchi we'll talk about later. So we see this posteriorly, you see this muscle, there's the cartilage rings anteriorly, like I said before, they're open. You can get that feel for the mucosal inner surface, and then the submucosa, and finally the adventitial layers as we look at the trachea. You see this is a microscopic view. You see the mucosal pseudostratified ciliated columnar epithelium, the lamina propria, which is made of connective tissue, the submucosa you see here, and then finally the hyaline cartilage you see out here. We talk about the bronchi, the subdivisions. The air passages undergo 23 orders of branching. So in other words, from the main stem trachea into the bronchi, there are 23 separations, if you will, or splitting, called bifurcations as it goes down to the smaller and smaller and smaller tubes, or the bronchioles, if you will, that enter the alveolar area. The branching pattern is called the bronchial respiratory tree. The trachea breaks down the right and left main stem bronchi. Each main stem bronchus enters the hilum of each lung. The right main bronchus is wider and shorter and more vertical than the left, which means it's more likely to take in foreign bodies if one inhales that. Each main bronchi branches into lobar, secondary bronchi. There are 3 lobes on the right. 3 lobes on the right lung and 2 on the left. And the reason that is because the left lung also has to account for the heart as it's located in there. So the heart kind of fills into what would be the 3rd lobe on the left. Each lobar bronchus or tube supplies each one of those lobes. Each lobar bronchus branches into segmental, or what we call tertiary bronchi, smaller bronchi, and the segmental bronchi divide repeatedly until the bronchioles are less than 1 millimeter in diameter. The terminal bronchus is the smallest, and they're actually less than a half a millimeter in diameter, so you get a feel what we're talking about. And you can see the trachea, main stem bronchi, and sort of the breakdown as we go down into the smaller and smaller and smaller bronchioles as we move down the smaller areas of the lung. The conducting zone structures, as we said before, are from the bronchi to the bronchioles. The structural changes occur. The cartilage rings give way to plates. Cartilage is absent from the bronchioles. Epithelial changes from pseudostratified columnar to cuboidal, and the ciliate goblet cells become very sparse. There's a relative amount of smooth muscle increases, so there's more smooth muscle as we get more distal. In the respiratory zone, the respiratory bronchioles and alveolar ducts, alveolar sacs, there's clusters of alveoli, sometimes called grape-like clusters. There's a little over 300 million alveoli, which account for most lungs volume, and are the main site for gas exchange in external respiration. And you get a nice feel for the alveoli as they're located at the end of the respiratory bronchioles. They look like little grape clusters, and you can see those little alveolar sacs. And the reason you see it is because it increases the potential surface area, allowing us to move gases much more efficiently. This is a microscopic view of that same thing. What you're seeing here is the bronchiole, and you see all the alveolar ducts inside as we look at that cross-section in that histology exam. The respiratory mucosa is about 0.5 micromillimeters thick, and it's a single layer thick, which allows for the air in the blood to move back, or allows the air to move back and forth between the alveoli and into the bloodstream. It's here where the capillaries are also one layer thick, made of just pure endothelium, one layer thick, which allows the oxygen to cross the alveolar tissue, the alveolar membrane, through the wall of the capillary, and to attach it, the oxygen to attach to the hemoglobin molecule within the red blood cells. And conversely, the CO2 is able to leave the hemoglobin, detach from the hemoglobin, to find its way across the capillary membrane, the capillary endothelial layer, through the alveolar layer, and out to the atmosphere. So the alveolar and capillary walls are fused basement membranes. The alveolar walls are single layer thick of squamous epithelium, type 1 cells, and they're scattered type 2 cuboidal cells, which secrete surfactant, which acts to decrease the friction of the alveolar movement during inhalation and exhalation. And there's also some antimicrobial proteins located here, which help to reduce potential of infection. What you're seeing here is the terminal branches of the bronchioles. You can see lots of smooth muscle. There's the alveoli, and you can see that the alveoli are just totally encased in those capillaries, which aid in the oxygen movement in and out of the capillaries, the oxygen and CO2. This is looking at the alveoli under electron microscopy. The alveoli are really surrounded by fine elastic fibers, and they contain open pores that connect to adjacent alveoli. That allows air pressure without the lung to be equalized, and it's not low, wasn't high in one place and low on the other. They house alveolar macrophages to help keep the alveolar surfaces sterile, so that macrophages are phagocytic cells, you remember, that eat anything foreign. You get a nice feel for the alveoli as we're looking at the squamous epithelium here, and you can start to see the movement of O2 and CO2 at the alveoli, where oxygen is brought in from the alveoli to become attached to the hemoglobin within the red blood cells, and CO2 is released from the red blood cells into the atmosphere. The lungs occupy all the thoracic cavity, of course, for the mediastinum, except for the mediastinum, where the for the heart and some of its cardiovascular structures and some other things are located. The root is the site of vascular and bronchial attachments, and the costal surface, the anterior, lateral, and posterior surface is really what we're talking about. You see the lung here, we're looking at cross-section of the lung, so the transverse section through the lungs. What you're seeing here is the posterior aspect, so you see the vertebral column, and anteriorly you can see the sternum. You see the mediastinum located centrally, and you can see the pulmonary cavities on each side. You can see where the entry of the arteries, veins, and the bronchi enter each lung cavity, if you will, and you get kind of a feel for what we're talking about. You should see the parietal layer on the outside, the parietal pleura, and then there's a space, a potential space, and then the visceral pleura located right up against it. So you get a really good feel for what we're talking about. We talk about where we're talking about the cross-section. The apex of the lungs is the superior tip of the lungs. They're located just deep, if you will, to the clavicles. The base is the bottom of the lungs, and they actually rest on the diaphragm. The hilum is on the mediastinal surface. It's the site for attachment of blood vessels, bronchi, lymphatic vessels, and nerves as they enter the lung. And the cardiac notch of the left lung is concavity that accommodates the heart, as we talked about before. The left lung is smaller, separated in 2 lobes by an oblique fissure. The right lung has 3 lobes separated by an oblique and horizontal fissures. The bronchial pulmonary segments, there's 10 on the right, 8 or 9 on the left, and the lobules are the smallest subdivisions, and they're served by the bronchioles and their branches. So let's see what we mean here. You see here that the left lung is really two lobes. There's a superior lobe and an inferior lobe, where the right lung has a superior lobe, has a right middle lobe, and has an inferior lobe. So the heart sort of takes place of this middle lobe here, if you were, and you get kind of a feel. And there's that cardiac notch located right there that allows for the heart proper. This is really a look at the lungs, directly right and left lung, looking at the bronchioles and the segments of that. You get a real nice feel for how it looks without all the tissue around it. Just really interesting. The blood supply, the pulmonary circulation, is obviously low pressure and high volume because, remember, the right side of the heart delivers that deoxygenated blood to the lungs. The pulmonary arteries from the heart, primarily from, or more specifically from the right ventricle, as it leaves the heart to the pulmonary valve, let's go backwards. The pulmonary arteries leave the right side of the lung, and they go move into the lungs proper, where they branch profusely along with the bronchi, and they feed in that capillary network. And it's at that capillary network where the blood is reoxygenated. The pulmonary veins, which are now carrying oxygenated blood from the heart, if you will, or from the lungs, if you will, return to the heart to enter into that left atrium. The systemic circulation, on the other hand, the left side of the heart, is really a high-pressure, low-volume blood supply. The bronchial arteries provide oxygenated blood to the lung tissue. They arise from the aorta and enter the lungs and the hilum, and they supply all the lung tissue except for alveoli. The bronchial veins anastomose with the pulmonary veins, ultimately, and the pulmonary veins carry most of venous blood back to the heart. So that's kind of how it works. The pleura, we've talked about in multiple chapters, is really that thin double-layered serosa that encases the lungs. There's the parietal pleura, which is the outside layer, which is primarily coating the thoracic wall of the superior face of the diaphragm. And the visceral pleura, which intimately touches and encases each lung surface. The pleural fluid fills the slit-like pleural cavity and provides lubrication and reduces surface tension. This is another cross-section. We've seen it before. Same thing we just talked about. The mechanics of breathing. The pulmonary ventilation consists of 2 phases, inspiration and expiration. Inspiration is where the gases flow into the lungs. Expiration is where the gases exit the lungs. So we're talking about breathing proper, inspiration versus expiration. The pressure relationships in the thoracic cavity is that the atmospheric pressure, PATM, or the pressure at atmospheric pressure, the pressure exerted by the air surrounding the body is about 766 millimeters of mercury at sea level. Respiratory pressure is described relative to that level, 760 millimeters of mercury. A negative respiratory pressure is less than 760. A positive respiratory pressure is greater than that 760, and zero respiratory pressure is really equal to that 760. So we're competing with the atmospheric pressure of to move air in and out of the lungs. The interpulmonary or interalveolar pressure is really the pressure in the alveoli, and it fluctuates with the breathing, but it always eventually equalizes to the pulmonary to the pressure in the atmosphere. The interpleural pressure, the IP, is the pressure in the pleural cavity. It fluctuates with breathing, and it's always a negative pressure, so it's always less than the atmospheric pressure and less than the pulmonary pressure. Negative interpleural pressure is caused by opposing forces. There's 2 inward forces that promote lung collapse. That's the elastic recoil of the lungs, which decrease the lung size, and the surface tension of the alveolar fluid, which reduces the alveolar size. An outward force tends to enlarge the lungs. That's the elasticity of the chest, which pulls the thorax outward. And those two things actually help to aid in our ability to inspire and expire. The interpleural pressure is equal to the pulmonary pressure if the lung collapses. The pulmonary pressure is equal to minus the interpleural pressure is the transpulmonary pressure. And this allows us to keep the airway open, and the greater the transpulmonary pressure, the larger the lungs. So let's look at this. We have the atmospheric pressure, that's 760 millimeters of mercury. We have the parietal pleura, the visceral pleura, and the transpulmonary pressure is really 760 millimeters of mercury, the atmospheric pressure, minus 756 millimeters of mercury, which equals that 4 millimeters we talked about, which is the interpleural, if you will, interpleural pressure. The interpulmonary pressure is really the 760, which means 0, comparatively 0. We talk about homeostatic imbalances. We're really talking about atelectasis, which is lung collapse due to plugged bronchioles, which collapses the alveoli, and the wound, if you will, that if you have a hole in the wall of the chest wall into the pleural cavity, that emits air into the pleural cavity and causes what's called a pneumothorax. You can have pulmonary ventilation is really inspiration and expiration. It's a mechanical process that depends on the volume changes in the thoracic cavity. As the volume changes, pressure changes. Pressure changes cause the gas to flow to equalize the pressure, and that's because the world, if you will, the universe is always trying to fill in negative pressures and trying to bleed off high pressures. So there's a law called Boyle's law, and that's the relationship between pressure and the volume of gas. What's really saying is that the greater the volume, if I increase the volume with the same amount of gas, I'll actually decrease the pressure. Inspiration is an active process. Inspiration is the active contraction of the diaphragm muscles. The inspiratory muscles contract, primarily the diaphragm. The thoracic volume increases, so basically the lungs are pulled down by the diaphragm as it contracts. The lungs are stretched and expanded, decreasing the decreased pressure in the lungs, so the pressure drops to a minus millimeter of mercury. And so air is, because the universe is trying to equalize that decreased pressure now in the lungs, air moves from the outside universe, if you will, to equalize with the atmosphere. So here we go. The first is inspiration muscles contract. The diaphragm descends. So the diaphragm moves down the rib cage. Thoracic cavity now volume increases because now the rib is the lung is expanded. The lungs are stretched as the interpulmonary volume increases. Because the lungs expand by Boyle's law, their pressure decreases by a millimeter of mercury. And finally, to equalize that, gases flow from the atmosphere through the airways into the lungs to equalize that, to make that the interpulmonary pressure equal to the atmospheric pressure, which is 760 millimeters of mercury. Expiration is really a relaxation phase. Quiet expiration is normally that passive process. It's an inspiratory muscles relax, primarily the diaphragm. The thoracic, it allows the diaphragm to move back up to its resting stage in the thorax superiorly. The lungs are then compressed by the diaphragm superiorly, and that creates an increased pressure in the lungs because now you have less volume and the pressure now goes up. That forces that pressure forces that extra air out of the lungs and into the atmosphere. Now, forced expiration is an active process. Well, forced expiration is a passive process and an active process. Forced expiration means that it uses abdominal intercostal muscles which are contracting to augment that quiet expiration. But regular expiration, just day to day, you're just sitting here, your lungs are sitting here moving, is really a relaxation process primarily of the diaphragm. If you're trying to blow out a candle or blow up a balloon or blow up an air mattress or whatever, then you use you actually contract your abdominal and internal intercostal muscles to augment that normal expiratory process. This is a sequence of events. Inspiratory muscles relax, the diaphragm rises in the diaphragm, which compresses the lungs, creating an increased pressure. The thoracic cavity volume decreases, the elastic lungs recoil passively, and that creates an interpulmonary volume, it decreases interpulmonary volume and causes the pressure to go up because the volume decreases. It forces air out of the airways, if you will, and thus it creates that expiratory event. Now, interpulmonary pressure, the pressure inside the lungs decreases as lung volume increases during inspiration, and pressure increases during expiration. Intrapulmonary pressure, the pleural cavity pressure becomes more negative as the chest wall expands during inspiration and returns that normal value as the chest wall recoils. And finally, the volume of breathing. During each breath, the pressure gradient moves 0.5 liters of air in and out of the lungs proper. There are several physical factors that influence pulmonary ventilation. Inspiratory muscles consume energy, or you have to do work to overcome three factors that hinder air passage and pulmonary ventilation. One is airway resistance. Excuse me. The airway resistance to air movement, the alveolar surface tension, and finally lung compliance, the elasticity of the lungs proper. Airway resistance. Friction is the major non-elastic source of resistance to gas flow. The relationship between flow, pressure, and resistance is as follows. Airflow, or airway flow, if you will, is equal to the pressure gradient between the atmosphere and the alveoli, which is 2 millimeters of mercury or less during normal quiet breathing, over R, which is resistance. And that gas flow changes inversely with resistance. Resistance is usually insignificant. It's usually insignificant because large airway diameters in the first part of the conducting zone allow air to move in quite nicely. The progressive branching of the airways as they get smaller increases the total cross-sectional area. Resistance really disappears in the terminal bronchioles where the fusion drives gas movement. And what you're seeing here is you see the conducting zone, you're seeing the you see the resistance as you see it increase as it gets to medium-sized bronchi, and then it starts to decrease. The resistance starts to decrease as you get down to those terminal bronchioles. As airways resistance rises, breathing movements become more strenuous. That makes sense. Severe constricting or obstructing of the bronchioles can prevent life-sustained ventilation, can occur during acute asthma attacks to stop ventilation, or any kind of injury to the bronchioles. For instance, if somebody gets a smoke inhalation or a chemical inhalation that cause the bronchioles to be inflamed, basically it constricts the bronchioles, which increases the resistance so that air can't be moved down to those terminal bronchioles. We use epinephrine to dilate bronchioles and help to reduce that airway resistance if those things occur. We talk about alveolar surface tension. That surface tension attracts liquid molecules to one another at the gas-liquid interface, and it helps to resist any force that tends to increase the surface area of the liquid. So basically, it's trying to reduce the surface tension to allow for better movement. Surfactant is a detergent-like lipid and protein complex produced by alpha-2 alveolar cells, and it reduces the surface tension of the alveolar fluid, and it discourages alveolar collapse, which is a good thing. Insufficient quality in premature infants causes what's called infant respiratory distress syndrome, which is IDS. And that what basically happens is when infants are born prematurely, they aren't able to produce surfactant. They'll do a test on them, which is called an LS test, which stands for lecithin single myelin, and that test will tell them potentially or indirectly whether the child is able to make its own surfactant, and that'll give them some great prognostic capabilities in determining what they're going to have to do for that premature child. Lung compliance is a measure of the change in lung volume that occurs with a given change in transpulmonary pressure. It's normally high. The lung compliance is high because the distensibility of the lung tissue. It's very elastic, and also the alveolar surface tension. So lung compliance is usually allows kind of snap back like a rubber band, and that so it doesn't just get expanded and it kind of sits there like a stretch rubber band. Lung compliance is diminished by non-elastic scar tissue, like in fibrosis from smoking, a reduced production of surfactant as in newborns, or a decreased flexibility of the thoracic cage because of injury. Homeostatic imbalances that reduce that compliance include deformities of the thorax, makes sense, ossification of the costal cartilages, or paralysis of the intercostal muscles, which limit the ability of the lungs to expand. We talk about respiratory volumes or respiratory volumes. They're used to assess a person's respiratory status. We're going to talk about tidal volume, inspiratory reserve volume, expiratory reserve volume, and finally residual volume. And there's an interrelationship between these four. The tidal volume is really the adult male will move an average of 500 mils of air that's moved under resting stages. If you have an inspiratory reserve volume, where you're really taking a really deep breath, not just your regular tidal breath, you'll increase that to about 3,100 mils in a male and about 1,900 in a female. If you also then, after you've taken a deep, deep breath, blow all the air out you can, you'll also expel your expiratory reserve volume, which is an additional 1,200 mils in men and about 700 mils of air in women. So the tidal volume is what happens when you're at rest. Inspiratory volume is when you're trying to take a deep breath. Expiratory volume, reserve volume, is when you're really trying to blow the air out. The residual volume is what always stays in the lung no matter what, unless the lungs are collapsed. And you want that to happen. So the lungs will always have about 1,200 mils of air for men and about 1,100 for women as they stay in the resting stage. We have respiratory capacities. We have inspiratory capacity, functional residual capacity, FRC, vital capacity, and total lung capacity. Total lung capacity is really the maximum amount of air that's contained in the lungs if you totally breathe in all you can and breathe out all you can. Total lung capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume plus the residual volume. That's the total lung capacity. The vital capacity is all of that except for the residual volume. So total lung capacity includes residual volume, where the vital capacity does not. The inspiratory capacity is really the tidal volume plus the inspiratory reserve volume. The functional residual capacity is really the volume that's air remaining in the lungs after a normal tidal volume. And that shows you where that's at. So you get kind of a nice feel for the various statements as we look through. And this takes you to that process of all those volumes looking at a spirometer. We also have dead space because some inspired air never actually contributes to the gas exchange. There's a anatomical dead space, which is the volume of air where the air just kind of sits in the conducting zones, about 150 mils of air. And there's an alveolar dead space, which is where the alveoli that cease to act in gas exchange due to collapse or obstruction or injury. Then there's total dead space. That's a sum of the above non-useful volumes. So these two together make up that total dead space. We look at pulmonary function tests. We usually use a spirometer. That's an instrument used to measure the respiratory volumes and capacities of the lung. Spirometer can distinguish between obstructive pulmonary disease and restrictive disorders. So obstructive pulmonary disease are a result of increased airway resistance like bronchitis, bronchial scarring, asthma. Restrictive disorders are a reduction of total lung volume due to structural or functional lung changes like fibrosis of the lungs or tuberculosis. The minute ventilation is really the total amount of gas flow in or out of the respiratory tract in 1 minute, so that's called minute ventilation. Forced vital capacity is the gas forcibly expelled after taking one deep breath. So if I take a deep breath and I force the air out, I get my forced vital capacity. Forced expiratory volume is really the amount of gas expelled during some very specific time intervals during the FVC. So FEV is a portion or a fraction of FVC. Increases in total lung capacity, FRC and RV, may occur as a result of obstructive disease. Reduction in vital capacity, total lung capacity, FRC and RV, result from restrictive diseases. Alveolar ventilation rate is the flow of gases in and out of the alveoli during a particular time. So alveolar rate is really the mils per minute. The frequency equals the breath per minute times that dead space over mils per breath. The dead space is normally constant. There's rapid shallow breathing, which decreases the AVR, or the alveolar ventilation. And this really looks at all of those, this little table here. Non-respiratory air movements include most result from reflex action. For instance, you cough, sneeze, cry, laugh, hiccup, or yawn. Those are non-respiratory movements, and they're reflexive. You cough based on your body saying cough. Gas exchange, we're going to talk about gas exchange between the blood, lungs, and tissues, and we're going to look more closely at what constitutes external respiration, what constitutes internal respiration. And first we have to really understand the physical properties of the gases and the composition of the alveolar gas. The basic property of gases follow what are called Dalton's law of partial pressures. That's the total pressure exerted by a mixture of gases, the sum of the pressures exerted by each gas. So basically the total pressure is really the sum of each of the gases' pressure. The partial pressure of each gas is directly proportional to its percentage of the mixture. Duh. So the more that makes up of that total pressure, the more effect it has on that mixture. And this talks about that. And here's looking at the atmosphere, if you will. You notice that nitrogen makes up almost 80% of the gases in the atmosphere, and then oxygen really makes up around 21%. CO2 is 0.04%, and water makes up 0.46%. So you get kind of a feel for what we're talking about. We talk about what makes up the atmosphere. Henry's law says that when a mixture of gases is in contact with a liquid, each gas will dissolve the liquid in proportion to its partial pressure. At equilibrium, the partial pressures in the two phases will be equal, so ultimately it'll all equal out. And the amount of gas that will be dissolved in the liquid also depends on its solubility. CO2, carbon dioxide, is 20 times more soluble in water than oxygen. And very little nitrogen dissolves in water. So when you look back and see that most of the air is nitrogen, it's really kind of an inert gas as far as we're concerned. The composition of alveolar gas, an alveoli contain more CO2 and water vapor than atmospheric air because gas exchanges in the lungs, humidification of the air, and the mixing of alveolar gas that occurs with each breath. And so it's kind of important to know that. So when we look at what's going on, you get a kind of feel for atmospheric sea level and the alveoli as we're looking through that. External respiration. External respiration, by definition, is the exchange of O2 and CO2, oxygen and carbon dioxide, across the respiratory membrane, that being the alveolar membrane between the alveoli and the blood, if you will, that have entered the lung. It's influenced by the partial pressure gradients and gas solubilities of oxygen and CO2, the ventilation perfusion coupling, and the structural characteristics of the respiratory membrane, whether it's scarred or not scarred. Partial pressure gradients and gas solubilities. Partial pressure gradient for oxygen in the lungs is steep. Venous pressure, the PO2, is about 40 millimeters of mercury. In the alveoli, it's about 104 millimeters of mercury. And so oxygen partial pressures reach equilibrium 104 millimeters of mercury in about 0.25 seconds, or about a third of the time a red blood cell is in the pulmonary capillary. So that oxygen moves across pretty quickly. You see that the capillary enters, time in the capillary, and you see that the capillary enters, the hemoglobin becomes oxygenated, and about a third of the time that it takes that capillary to move that red blood cell through the system. The partial pressure gradients and partial pressure gradients and gas solubilities of CO2 in the lungs is different. The venous blood, the PCO2, or the is 45 millimeters of mercury, and the alveolar PO2 is 40 millimeters of mercury. Not a great deal of difference, only 5 millimeters. CO2 is 20 times more soluble in plasma than oxygen, and CO2 diffuses in equal amounts with oxygen. So it's really interesting to know how the two differ. And you get kind of a nice feel here for what we're talking about. This looks at, this gives you a feel for as oxygen is moving, there's brain and body. You get a feel for external respiration and the pulmonary veins as they're moving back between the lungs, and the pressures that are located there we just talked about. The ventilation-perfusion coupling, ventilation is the amount of gas reaching the alveoli, and perfusion is the blood flow that reaches the alveoli. So ventilation-perfusion coupling is really how much air we bring in and how much blood we bring in at that point within the lungs. Ventilation and perfusion must be matched or coupled to make it efficient. If your perfusion is down, it doesn't matter how much air you bring in. If your air capacity is down, you can't bring in air, it doesn't matter how much blood you bring in. And so changes in the PO2 in the alveoli cause changes in the diameter, the size of the arterioles. Where the alveolar O2 is high, the arterioles dilate. Where the alveolar O2 is low, the arterioles constrict. Changes of PCO2 in the alveolar causes changes in the diameters of the bronchioles also. Where the alveolar CO2 is high, the bronchioles dilate. Where the alveolar CO2 is low, the bronchioles constrict. Almost the opposite. And this takes you through that step-by-step process as you're looking at what happens as O2 is regulated in the alveolar constriction. The thickness of surface area of the respiratory membrane, the respiratory membranes, or the alveolar membrane, is 0.5 to 1 nanometers thick. It's a large total surface area, 40 times that of one's skin. Some people say it's actually 15 square feet of tissue. And it thickens as the lungs becomes waterlogged and edematous because it gets full of fluid, and gas exchange becomes inadequate. In congestive heart failure, where blood is backed up in the lungs, and the lungs become engorged with blood and plasma, that respiratory membrane becomes engorged with blood and fluid. It does not allow the movement of gas. Reduction of surface area with emphysema, which destroys the walls of adjacent alveoli and breaks them down, also reduces that. Internal respiration. So we talked about the lungs now. We'll talk about internal respiration. Internal respiration is the exchange of gases, oxygen and CO2, at the tissue level throughout the rest of the body. Not the lungs, the rest of the body. And that's where there's capillary gas exchange in body tissues. That means that the tissues, if you know, the partial pressure and diffusion gradients are reversed compared to the external respiration. That is, PO2 in the tissue is always lower than the systemic arterial blood, which forces the oxygen across the artery into the tissue. It tries to equalize that pressure. Where PO2 of venous blood is 40 millimeters of mercury and PCO2 is 45 millimeters of mercury. And that gives you that same view. We're just looking at that same chart. The transport of respiratory gases by the blood, respiratory gases, talks about oxygen transport and carbon dioxide transport. Oxygen transport, molecular oxygen is carried in the blood. 1.5 is in dissolved plasma, not very much. And so 98.5 is loosely bound to each ferrous molecule of the hemoglobin in the red blood cells. Each ferrous molecule, there's 4 ferrous molecules, and so 4 oxygen O2s, if you will, are able to be carried by the hemoglobin. Oxyhemoglobin is really hemoglobin with oxygen added. So oxyhemoglobin means hemoglobin with the oxygen attached to it. Reduced hemoglobin, HGB, reduced hemoglobin, HHB, is really hemoglobin that's released the oxygen, and you may call it deoxygenated hemoglobin. So HHB plus O2 goes to the lungs and the tissues, and you see that equilibrium back and forth. Loading and unloading of O2 is facilitated by a change in shape of the hemoglobin. As O2 binds, the hemoglobin affinity for O2 increases. As the O2 is released, the hemoglobin for the affinity of oxygen is decreased. There's fully 100% saturated if all 4 heme groups carry the oxygen. It's partially saturated when 1 to 3 hemes carry the oxygen. So those heme groups can carry 4 oxygens, but there can be something less based on all sorts of different problems. The rate of loading and unloading oxygen is regulated by the oxygen, the pulmonary oxygen, temperature, blood pH, the amount of PCO2 is present in the blood, and the concentration of BPGs. The influence of PO2 in the hemoglobin saturation is the oxyhemoglobin dissociation curve. Hemoglobin saturation is plotted against PO2. It's not linear. It's an S-shaped curve. And it shows how binding release of oxygen is influenced by that PO2. You're seeing this S curve as you go. And so you see that percent of oxygen saturation, if you will, and that unloading to resting tissues, the additional O2 loading to exercise tissues, you can see how that changes, and that resistance, if you will, at O2 saturation changes based on that curve. The influence of PO2 on oxygen saturation is, in the arterial blood, PO2 equals 100 millimeters of mercury. It contains 20 mils of oxygen per 100 mils of blood, 20% volume. So hemoglobin is 98% saturated. It further increases in PO2. Breathing deeply produces a minimal increase in the O2 binding. So by taking a deep breath, you can increase that a little bit, but not much. You can hyperventilate to a point where you can increase that a little higher, but not much. There's only a maximum level. In the venous blood, PO2 equals oxygen equals 40 millimeters of mercury. It contains 15% volume of oxygen, and the hemoglobin is 75% saturated. So look at that here. You can see that it's funny that you see 25 mils per 100 mils of blood, so almost 20% oxygen in the arterial side and only 15% oxygen in the venous side. And that makes sense because we use about 6% of the oxygen from the air. So the oxygen in the air, the atmospheric oxygen is about 21%. We tend to use about 6% in each of our, we take out 6% of that 21% with our respirations. The influence of PO2 on hemoglobin saturation. Hemoglobin is almost completely saturated at PO2 of 70 millimeters of mercury. There are further increases in PO2 which produce only a small increase in the oxygen binding. O2 loading delivery of tissues is adequate when the PO2 is below normal levels. So you can actually do okay even if it's low. The influence of PO2 on hemoglobin saturation, only 20 to 25% of bound O2 is unloaded during one systemic circulation. If O2 levels in tissue drop, more oxygen dissociates from hemoglobin and is provided to the cells. Respiration rate or cardiac output need not increase at this level. It'll just release more oxygen. So only about 25% of the bound oxygen in a normal person is released that we take in. And this is basically looks at that again. You see that as we see that oxyhemoglobin curve. Other factors influencing hemoglobin saturation: increases in temperature, hydrogen, PCO2, and BPG. To modify the structure of hemoglobin, decreases affinity for O2. It occurs in systemic capillaries. It enhances O2 unloading, and it shifts the oxyhemoglobin dissociation curve to the right. And any decrease in these factors shifts the oxyhemoglobin curve to the left. So it moves to the left. So normal temperature, if you move to the right, if higher temperature moves to the right, lower temperature moves to the left. And so you get kind of a feel for how that works. Factors that increase the release of oxygen by hemoglobin. As cells metabolize glucose, PCO2 and hydrogen increase in concentration in the capillary blood. A declining pH weakens the hemoglobin O2 bond called the Bohr effect. Heat production increases. If heat production increases, it increases the temperature directly and indirectly decreases the hemoglobin affinity for oxygen. So an increased temperature can really affect the hemoglobin's ability to take in oxygen. A increased concentration of PCO2 and hydrogen actually weakens that hemoglobin oxygen bond also. Hypoxia is one of the homeostatic imbalances. Hypoxia is an inadequate oxygen delivery to the tissues. I think we do to a variety of things. You can have a blood loss, if you will, so the red blood cells are being lost due to bleeding outside of the circulatory system. You can have the right amount of blood cells, but something wrong or something not enough hemoglobin. You can have a block to the circulation, so it's not getting to the tissues. You can have poisons in the body like carbon monoxide, which is displacing oxygen on the hemoglobin molecule, and so oxygen isn't getting to the tissues. You can have pulmonary disease, which decreases the external respiration and decreases the amount of oxygen that's taken in the first place. And I talked about carbon dioxide earlier. We talked about that blocking. CO2 transport. CO2 is transported in the blood in three forms. 7 to 10% is dissolved in the plasma, as opposed to 1.5% of the oxygen. 20% is bound to globin, the globin of hemoglobin, in carbonyl hemoglobin, or you'll see the term carboxyhemoglobin. But 70% is transported as a bicarbonate ion, HCO3, in plasma. So most of it's transported as plasma in the blood. This talks about how that works. So CO2 combines with water to form carbonic acid, H2CO3, which quickly dissociates. Most of the above occurs in red blood cells, where carbonic anhydrase reversibly and rapidly catalyzes the reaction. In the systemic capillaries, HCO3 quickly diffuses from the red blood cells in the plasma, and the chloride shift occurs where there's an outrush of HCO3 from the RBCs and is balanced as the chloride moves in from the plasma. And so you get a really nice feel for what's going on here. We talk about oxygen release and carbon dioxide pickup in the tissues. What we're seeing is we're seeing the red blood cell moving oxygen from the red blood cell into the tissues. You're seeing CO2 moving back out of the tissues, back into the blood, some of it being attached to the hemoglobin, it's carboxyhemoglobin, some of it being attached to the water as carbonic acid, and finally some which is just dissolved in the plasma. We talk about transport and exchange of CO2 in the pulmonary capillaries. HCO3 moves into the red blood cells and binds with the hydrogen to form H2CO3. The H2CO3 is split by carbonic anhydrase into CO2 and water, and then the CO2 diffuses into the alveoli, where it's expelled during external respiration. Again, in external respiration, oxygen is taken in from the outside world via the alveoli. It's dissolved as oxyhemoglobin, about 95% of that, and 98% of that, and 1.5% is actually dissolved in the plasma. There's a Haldane effect where the amount of CO2 transported is affected by the PO2. The lower the PO2, the oxygen in the arterioles, and the hemoglobin saturation with O2, the more CO2 can be carried in the blood. So basically what happens if there's not enough oxygen, the hemoglobin will start carrying CO2. So it sort of you have what's called a carbon dioxide buildup, called the Haldane effect. At the tissues, as more carbon dioxide enters the blood, more oxygen dissociates from the hemoglobin, calling the Bohr effect, and as HbO2 releases oxygen, it more readily forms bonds with CO2 to form more carbonyl hemoglobin, or carboxyhemoglobin is the other term for the same thing. The influence of CO2 on blood pH. HCO3 in plasma is an alkaline reserve of the carbonic acid bicarbonate buffer system. If the hydrogen concentration in blood rises, you have excess of hydrogen, which makes the blood more acidic. It's removed by combining with the HCO3, and so the H2 concentration begins to drop. H2CO3 dissociates, releasing the hydrogen. So let's take it back. If the blood becomes acidic, the body will take in that hydrogen, or the body will take the hydrogen and combine it with HCO3. If the HCO3 begins to drop, or the blood becomes alkaline, the body will release that hydrogen back out from that bicarb, and then release that free hydrogen, making the blood more acidic. The influence of CO2 on blood pH. Changes in respiratory rate can also alter the blood pH. For example, slow, shallow breathing allows CO2 to accumulate in the blood, which causes the pH to drop because it becomes more acidic. CO2 making it acidic. Changes in ventilation, a faster ventilation, can adjust the pH. So if somebody starts to become acidic, they'll sometimes hyperventilate them to blow off the CO2 and make the blood less acidic. The control of respiration involves neurons and the reticular formation of the medulla and the pons in the brainstem. The medullary respiratory centers, the dorsal respiratory group, DRG, is near the root of the cranial nerve 9. We've talked about this before. We did the autonomic nervous system. It integrates input from the peripheral stretch and chemoreceptors within the circulatory system. The ventral respiratory group, the VRGs, is a rhythm-generated and integrated center. It sets eupnea, which is normal breathing, 12 to 15 breaths per minute. And the inspiratory neurons excite the inspiratory muscles via the phrenic and intercostal nerves, the phrenic nerve being the nerve that innervates the diaphragm. The expiratory neurons inhibit the inspiratory neurons. And so you get a feel for what's going on here as we go through. We have the pontine respiratory centers. They interact with the medullary respiratory centers to smooth the respiratory pattern, giving us eupnea. The ventral respiratory group, VRGs, contains the rhythmic generators who output drives respiration. So see the pons of the medulla. And the dorsal respiratory group, which integrates peripheral sensory input and modifies the rhythm generated by the VRG. Pontine respiratory centers influence and modify activity of the VRG, and they smooth out transition between inspiration and expiration, and vice versa. The genesis of the respiratory rhythm is not well understood. Most widely accepted hypothesis is reciprocal inhibition of two sets of interconnected neuronal networks work in the medulla to set the rhythm. So they're really a dynamic opposition going which sets that rhythm. The depth and rate of breathing, the depth is determined by how actively the respiratory center stimulates the respiratory muscles. The rate is determined by how long the inspiratory center is active. Both are modified in response to changing body demands, so depth and rate are different. It's good to know that. Chemical factors. The influence of PCO2 or CO2 in the blood. If the PCO2 levels rise, that's hypercapnia, or increase in CO2, CO2 accumulates in the brain. CO2 is hydrated, resulting in carbonic acid, which dissolves and releases hydrogen. Hydrogen stimulates the central chemoreceptors of the brainstem. Chemoreceptors synapse with the respiratory regulatory centers and increase the rate and depth of breathing. So PCO2 has a really strong effect. Here's what's really interesting. If you smoke, it actually numbs up the PCO2 factors. The PCO2 factors, if you will, the PCO2 sensors, chemoreceptors, are incremental, and that means that they can increase your breathing a little bit, decrease it a little bit, decrease it a lot, increase it a lot. And so that allows that CO2 is the most sensitive of the receptors. When you smoke, you basically create a high CO2 environment that sort of numbs up those receptors. And so in older folks, they don't really have these anymore, and it doesn't work very well. What they have is they have to use oxygen as their sensor. So here's the problem. Oxygen, we'll go back here, oxygen sensors are really on-off switches. They say if the oxygen level is low, the PO2 is low in your bloodstream, it says breathe. If the oxygen is at a good level, it says stop breathing. So if you take people who have been smoking most of their lives and you give them too much oxygen, guess what? The brain says don't need to breathe anymore, and they stop breathing. So you have to really monitor that. So that's one of the things that smoking does, is it knocks out these CO2 receptors. This takes you to that process of arterial CO2. The depth and rate of breathing. Hyperventilation increases the depth and rate of breathing that exceeds the body's need to remove CO2. So it causes CO2 levels to decline, causing hypocapnia. That can cause cerebral vasoconstriction and cerebral ischemia. And so what do you do when you hyperventilate? Eventually you pass out because your body can't take that. And so your body tries to equalize that. Apnea is a period where you don't breathe at all. And that occurs when the PCO2 is abnormally low. And so you get kind of a feel for what's going on here. Some chemical factors, the influence of PO2. I said this before. We have peripheral chemoreceptors in the aortic and carotid bodies, or CO2 sensors, and when excited, they cause the respiratory centers to increase ventilation. Guess what? When they're really high, they tell it to shut off. And so substantial drops in arterial PO2 must occur in order to stimulate that increased ventilation. So if they're really going well, then they don't tell you to breathe. And this talks about how that sensory process works, and we've already talked about that before. Some influence of arterial pH. pH can modify the respiratory rate and rhythm even if CO2 and oxygen levels are normal. A decreased pH may reflect CO2 retention, accumulation of lactic acid, or an excess amount of ketone bodies in patients who have diabetes mellitus. The respiratory system controls will attempt to raise the pH, by increasing the respiratory rate and depth. So they're trying to raise that ascetic level by increasing the respiration rate and depth, thus blowing off CO2 to try to equalize that balance. Rising CO2 levels are the most powerful respiratory stimulant, and they are the ones that knocked out smoking. Normal blood PO2 affects breathing only indirectly by influencing peripheral chemoreceptors sensitivity changes in PCO2s. So that PO2 is really important. When arterial PO2 falls below 60 millimeters of mercury, it becomes a major stimulus for respiration via the peripheral chemoreceptors. Changes in arterial pH resulting from CO2 retention or metabolic factors act indirectly through those peripheral chemoreceptors. The hypovolemic controls act through the limbic system to modify the rate and depth of the respiration. For example, if you hold your breath that occurs in anger or gasping with pain, guess what? They'll ultimately take control. A rise in body temperature also acts to increase the respiratory rate, to blow off more heat. Cortical controls are direct signals from the cerebral motor cortex, and they bypass the medullary controls, and that's where you hold your breath voluntarily. So it can circumvent them. Receptors in the bronchioles respond to irritants, so you have pulmonary irritant reflexes. They promote a reflexive constriction of the air passages, and the receptors in the larger airways mediate the cough and sneeze reflex. So these work together to expel anything that's foreign in your lungs. You have an inflation reflex called a Herring-Brewer reflex. That's where stretch receptors in the pleural and airways are stimulated by lung inflation. The inhibitory signals the medullary respiratory centers end inhalation and allow expiration to occur. They act more as a protective response than a normal regulatory mechanism. They're kind of a protective thing so you don't blow your lungs out. And this talks about how all those work, and those stretch receptors is a great graphic and a great one to take a look at. We have respiratory adjustments like in exercise. Adjustments are geared to both the intensity and duration of exercise. If you have hyperpnea, which is an increase in ventilation, which can be 10 to 20-fold in response to metabolic needs. So you start to run, you need more oxygen. The PCO2, PO2, and pH maintain surprisingly constant during exercise because of the compensatory mechanisms that occur by increasing the rate of respiration and the rate of heart rate and the rate of respiration, so that the supply increases to match the needs. There are three main neural factors which cause increase in ventilation as exercise begins: psychological stimuli, the anticipation of exercise, and the simultaneous cortical motor activation of the skeletal muscles and respiratory centers. And there's the excitatory impulses which reach the respiratory centers. As exercise ends, ventilation declines suddenly as the three neural factors shut off, so eventually you sort of go back to normal. High altitude. Quick travel to high altitudes above 8,000 feet can produce symptoms of acute mountain sickness or hypoxia. Headaches occur, shortness of breath, nausea, and dizziness, and actually you can lose some neural control. In severe cases, lethal cerebral and pulmonary edema, and people will lose their ability to function. The accumulation or acclimation to high altitude. Acclimation is where the respiratory and the hematopoietic adjustments occur at altitude. The chemoreceptors become more responsive to CO2 when the PO2 declines. Substantial decline in PO2 directly stimulates the peripheral chemoreceptors, and the result, minute ventilation increases and stabilizes in a few days to 2 or 3 liters per minute higher than at sea level. So the higher you go, the faster the ventilation occurs, the rate increases. Accumulation high altitude is if there's a decline in blood oxygen, stimulates the kidneys to accelerate the production of erythropoietin hormone, and so more RBCs are created, which create more of increase the body's ability to move oxygen and CO2. Some other homeostatic imbalances include chronic obstructive pulmonary disease, COPD. It is exemplified by chronic bronchitis and emphysema, and that's irreversible decrease in the ability of forced air to force air out of the lungs. Other common features include a history of smoking in 80% of patients, dyspnea, which means you have air hunger, it's hard to breathe, coughing and frequent pulmonary infections, and most victims develop respiratory failure or hypoventilation accompanied by respiratory acidosis because of the accumulation of the CO2. This takes you through all those processes. Really a nice look here. Asthma is another homeostatic imbalance, and sometimes asthma has been associated or is actually included in COPDs, believe it or not. It's characterized by coughing, dyspnea, wheezing, and chest tightness. It produces an active inflammatory response to the airway, the mucosa of the airway, which causes bronchial spasms or the bronchioles to spasm close. Airway inflammation is an immense response caused by the release of interleukins, the production of IgE antibodies, and the recruitment of inflammatory cells in the area. And so it actually thickens the area and becomes inflamed. Its airways are thickened with inflammatory exudate, and so they magnify the effect of the bronchial spasms. Tuberculosis is an infectious disease caused by the bacterium, Mycobacterium tuberculosis. The symptoms include fever, night sweats, weight loss, a racking cough, and spitting of blood. The treatment entails as much as 12-month course of antibiotics. Tuberculosis used to be a disease of the past. We didn't see much of it. In Europe and in Asia, they actually use BCG, which is a vaccination for tuberculosis, because after World War II, there was an epidemic and they needed to stop it. In the United States, we don't use BCG, and the reason we don't is because BCG actually masks a person if they get tuberculosis. BCG causes you to produce antibodies against tuberculosis. The problem is that people just get their first dose for their first case of tuberculosis, and if they've had BCG, you don't know whether they have antibodies that are produced because of BCG or antibodies that are produced because of the tuberculosis. So it's just a different attitude towards the treatment and the prevention of tuberculosis in the United States. Lung cancer. Lung cancer is the leading cause of cancer deaths in North America. 90% of all cases are really caused by smoking, and smoking in the primary sense of the user or secondary smoke. And there are three major types of cancers that we look at. There are lots of them, but three major types. Squamous cell carcinoma, which makes up about 20 to 40% of cases in bronchial epithelium. Adenocarcinoma, which is about 40% of the cases and originates in the peripheral lung areas. And small cell carcinoma, 20% of the cases, which contains lymphocyte-like cells that originate in the primary bronchi and subsequently metastasize throughout the body. All right. So we've gone through the chapter 14. We've talked about the respiratory system. This is the chapter 21 of the respiratory system. Have a good day.